Rain still clings to the asphalt outside a civilian emergency room near Andersen Air Force Base in Guam after a tropical squall. Inside, fluorescent lights glare off steel and tile while monitors hammer a fast rhythm, and alarms chirp and buzz. Families pack the hallway and cameras crowd the entrance, hungry for a glimpse of certainty and whispered prayers. The air smells like disinfectant and wet gear as stretchers roll in from a multi-vehicle crash from the loading bay. 6 service members arrive at once, each in a different kind of trouble and bleeding edges to the margins. Dr. Lauren Carter is new to this hospital. Quiet, steady, and easy to underestimate. Fresh badge still stiff on her coat. She moves with economy, asking for vitals, scanning faces, already building a map of priorities while nurses jockey gurneys into position. In this room, rank is noise, and physiology is the compass that decides who goes first and nothing else. Brigadier General Robert Whitaker is wheeled in, pale and fading, neck veins full, pressure dropping rapidly. At his side, aide-de-camp Captain Aaron Doyle presses for VIP priority, while staff glance toward the doors for a promised specialist. Carter keeps her voice level and lays out the rule of implied consent for life-threatening emergencies, then pushes the team to treat the dying first. The scene narrows to a single image as an ultrasound probe settles on a chest. Sound, tracing truth through chaos that everyone can follow now. The night sits heavy and damp over Guam after rain, and the civilian hospital near Andersen Air Force Base breathes like a crowded harbor. Fluorescent light spreads across linoleum, carts, and pale curtains while monitors tick in tight little bursts that seem to merge with footsteps. Families cluster near the entrance and television crews hover by the doors. Lenses pointed at the storm-bright lobby. The charge nurse tracks arrivals on a board that is already full, as 6 injured service members approach at the same time. The intake clerk relays the first constraint from the blood bank, and it lands like a boundary line drawn across the room. Only a limited number of packed red blood cells, fresh frozen plasma, and platelets can be released immediately. With more units delayed by distance and weather, the team confirms that a massive transfusion protocol is ready to run with a 1:1:1 ratio once Carter calls it. Warmers hum. Blankets stack on carts. And runners check tubing and labels with practiced hands. Power starts to gather at the edges of the bay as reality collides with image management. Hospital Administrator Karen Blake moves to control the hallway and the cameras while asking for updates that will not compromise privacy. Captain Aaron Doyle, aide-de-camp to Brigadier General Robert Whitaker of the United States Army, pushes for VIP priority and repeats that a visiting specialist is on the way. Dr. Lauren Carter answers without ceremony that in a life-threatening emergency, the team proceeds under implied consent and that clinical decisions follow physiology, not rank. Carter's history flickers at the margins and then hides again. A habit learned the hard way. She once served with a Navy Expeditionary Medical Facility Detachment at Roll 2 and Roll 3, and it taught her to distrust applause and to keep her eyes on the algorithm. She scans the arriving stretchers and hears the pattern of likely injuries before the words are complete. Unstable pelvic fractures, an airway at risk, and signs that point toward attention pneumothorax set the order of work, while the chain of command for non-clinical matters remains with the uniform side and clinical command stays with the emergency physician. The doors swing open as 6 stretchers flood the civilian emergency room near Andersen Air Force Base in Guam after the convoy crash. Wet uniforms drip onto tile. Monitors tick fast, and the air carries diesel, rain, and disinfectant. Family members press into the hallway while television crews hover by the entrance with restless lights. The triage board fills in seconds and voices rise without shape as gurneys skid into assigned bays. Patient A arrives pale and restless, with pelvic instability and a widening pulse pressure that worries the team. A pelvic binder is ordered immediately to close the ring. reduce hidden bleeding, and buy time for definitive control. Patient B breathes hard. One hemithorax lifts less. Oxygenation falls on the monitor. An ultrasound shows absent lung sliding on one side. The team flags likely tension pneumothorax and readies decompression equipment while airway supplies stack on the cart. Brigadier General Robert Whitaker arrives unconscious with cool skin, distended neck veins, and a rapidly dropping pressure with a racing pulse. At his shoulder stands Captain Aaron Doyle, aide to the general, asking for priority as cameras thrum beyond the doors. Hospital Administrator Karen Blake worries about optics and privacy while trying to move the press back without raising the temperature. Command feels like a vacuum since many speak at once, and almost no one closes the loop after giving or receiving a task. Dr. Lauren Carter steps forward, ignores the tug of rank, and calls the room to order with simple assignments and confirmations. Airway team to bed 3. Breathing team to bed 2. Circulation to the patient with pelvic instability, and verify readiness with names and roles. The blood bank updates availability, confirms that Massive Transfusion Protocol can start on command with a ratio of 1:1:1, and warns supplies are limited. Warm fluids, large bore access, and focused ultrasound become the language of the room, while clinical command stays with the emergency physician and non-clinical matters track the uniform chain. Carter asks for vital signs every 2 minutes. Nurses speak back each order so nothing drifts. The chaos bends and the work finds shape for now. Captain Aaron Doyle plants himself at the head of the gurney and urges the team to move Brigadier General Robert Whitaker to the front of the line. His voice carries the weight of a staff officer guarding a wounded principal, and the hallway seems to tilt toward him. Hospital Administrator Karen Blake hovers near the doors, balancing privacy concerns and cameras, and reminds the staff that a visiting specialist is on the way. The room feels pulled by two tides that have nothing to do with blood pressure. Dr. Lauren Carter steps into the space between urgency and influence, with a posture that reads, "Respect without surrender." She states that in a life-threatening emergency, the team operates under implied consent and that treatment priorities are set by physiology. She adds that clinical command in this emergency room resides with the attending physician, while the uniform chain of command controls non-clinical issues outside the bay. She addresses Doyle as captain and addresses Whitaker as general, honoring titles while anchoring the work to vital signs. Carter implements a clear model that trims noise and multiplies focus. One medical commander and multiple task leaders, each with a lane, each answering back. Charge nurse manages the flow and the family corridor. Security clears the media lines to the outer threshold and holds the perimeter so the teams can hear themselves think. She points and assigns without raising her voice. Airway team to bed 3 for the patient with stridor and cervical precautions. Confirm readiness. Breathing team to bed 2 with decompression kit and chest tube tray. Confirm readiness. Circulation lead to patient A for pelvic binder placement and large bore access. Confirm readiness. The teams respond in closed-loop cadence that steadies the room. Names and tasks are repeated back. Timestamps are called out. And equipment is checked out loud, so nothing hides in silence. Karen Blake moves the cameras back another few feet and nods to security. Captain Doyle holds position at the side of the general and watches the order take root. By the end of a single lap around the bay, there is one voice directing and many voices confirming. Carter keeps the tone steady and the decisions short, and the staff begins to follow the rhythm. Respect for rank remains intact. The work still follows the pulse. Pelvic instability shows early in the first minutes. So Dr. Lauren Carter gives a clear order to place pelvic binders on the patients with suspected unstable fractures. The team slides the devices under the hips and cinches them tight to close the pelvic ring and slow hidden bleeding. Vital signs begin to settle a little on the monitor as nurses pace the room and check pulses at the wrist and ankle. Carter reviews mechanism and exam findings and marks these patients for rapid imaging once resuscitation holds steady. The blood bank confirms that Massive Transfusion Protocol can start on command with a 1:1:1 ratio for packed red blood cells, fresh, frozen plasma, and platelets. Warmers click on and blankets go up, while a respiratory therapist tapes temperature probes to track heat loss. Calcium is scheduled at regular intervals to counter citrate from blood products, and tranexamic acid is considered within 3 hours of injury for heavy bleeding. Carter keeps one eye on lactate and hemoglobin, while the other scans for early signs of coagulopathy. Access becomes the next gate, so 2 large-bore peripheral lines go into each unstable patient, with intraosseous access ready if veins are not available. Monitors run across the beds with heart rate, pressure, and pulse oximetry. An end, tidal carbon dioxide, is set where appropriate. Targets for mean arterial pressure are stated and repeated by the leaders, so every hand aims for the same range. Runners check tubing, labels, and warmers out loud, so the room hears each confirmation. Airway risk rises on the board, and the airway team sets up for rapid sequence intubation, with inline stabilization to protect the cervical spine, a 7.5 endotracheal tube, a bougie, and suction are arranged within easy reach, and medications are drawn with labels facing up. After placement, the team confirms position with end tidal carbon dioxide, and then with breath sounds over the chest and absence over the stomach. Captain Aaron Doyle of the United States Army stands near Brigadier General Robert Whitaker, and Carter addresses him by rank with respect while maintaining clinical command for treatment decisions inside the bay. Closed-loop communication tightens as each leader repeats orders and reports back status. The charge nurse coordinates transport paths and keeps families clear, and security holds the media at the outer threshold. Massive Transfusion Protocol runs clean. Pelvic binders hold, and airway plans are locked. For the first time since the doors opened, the room feels ordered. The work is synchronized, and the vital signs begin to drift in the right direction. Patient B begins to slide. Oxygen saturation falls. The pulse climbs, and one side of the chest lifts less with each breath. Bedside ultrasound shows no lung sliding on that side, with a sharp pleural line that stays still. The picture fits tension, pneumothorax, and the room tightens around that fact. Dr. Lauren Carter calls for immediate decompression without waiting for imaging. The team marks the 4th or 5th intercostal space at the anterior axillary line on the affected side. Antiseptic goes on. A small incision follows, and blunt dissection reaches the pleural space. A finger enters, releases trapped air, and the chest wall softens under a longer breath. Closed-loop responses roll back to Carter so nothing is missed. Position confirmed at the marked space and time logged near 7:15 p.m. Oxygen saturation rises point by point. The pulse eases, and the patient's color returns to something closer to normal. Respiratory rate slows into a safer groove. Carter directs definitive control before the room can drift. A chest tube is placed through the same tract and guided into the pleural space, then connected to an underwater seal with suction as available. The tube is secured and dressed, and breath sounds are checked on both sides with absence over the stomach. End-tidal carbon dioxide traces more stable as the patient settles into assisted ventilation. Cameras hum beyond the doors and the hallway noise pushes at the edges. But the bay holds its shape. Security keeps the threshold clear so the team can hear each other. Captain Aaron Doyle stands near Brigadier General Robert Whitaker and receives a quiet update with proper respect for rank. Carter keeps clinical command on the patient in front of her, and the room follows the rhythm of simple orders and clear confirmations. The monitor numbers tell the story better than any speech. Oxygenation now sits in a safer range. Chest rise is more symmetric. The team resets equipment and notes the next goals, while the work moves forward. Two patients with suspected unstable pelvic fractures already wear pelvic binders. Yet one remains in shock despite early steps. Dr. Lauren Carter holds the line and continues Massive Transfusion Protocol with a 1:1:1 ratio. Warmers stay on. Blankets cover exposed skin. And the team tracks core temperature closely. Lactate, hemoglobin, and calcium are checked and charted, so trends are visible in real time. Calcium replacement is scheduled at regular intervals to offset citrate from blood products. The team confirms inventory with the blood bank and plans the next release of units before the current cooler runs out. Nurses verify product labels and tubing allowed, so every set of hands hears the same plan. Carter repeats target ranges for mean arterial pressure to keep attention on goals rather than noise. Shock persists in the bindered patient. So, Carter considers endovascular control. She calls for a physician trained in catheter placement and states the indication for resuscitative endovascular balloon occlusion of the aorta in Zone 3. Continuous hemodynamic monitoring is confirmed, with fluoroscopy preferred and vascular ultrasound prepared if imaging support is limited. The room adjusts lighting and gathers the arterial access kit while keeping resuscitation steady. Safety checks continue in parallel, so speed does not erase judgment. The team evaluates the urethra before any urinary catheter, looking for blood at the meatus and assessing pelvic stability again. Focused assessment with sonography for trauma continues to sort patients with intra-abdominal fluid toward an operating room pathway. Closed-loop communication links leaders for airway, breathing, and circulation, so tasks begin and finish without gaps. Captain Aaron Doyle asks about operating room priority for Brigadier General Robert Whitaker with a steady voice that carries duty. Carter answers with respect for rank while tying triage to physiology. And the charge nurse repeats the plan for everyone to hear. Blood warms. The binder holds. And the Zone 3 option remains ready if pressure falls again. The plan now feels coherent. Resources are pointed at the right problems, and hemodynamic targets begin to stabilize. Dr. Lauren Carter takes the ultrasound herself and starts the exam in the right upper quadrant, then moves to the left upper quadrant, the pelvis, and finally the pericardial window. The probe slides over gel, while the room quiets just enough to hear the machine. She sweeps each view with steady hands and a practiced eye, then pivots back to the chest to check for lung sliding, so no hidden pneumothorax lingers. The pattern is calm, repeatable, and built for chaos. She reaches Brigadier General Robert Whitaker and sets the probe beneath the sternum for a subxiphoid view. Dark fluid halos the heart, and the right ventricle buckles in early diastole, while the inferior vena cava looks distended with little respiratory collapse. The blood pressure is low. The pulse is fast. And the ultrasound matches the story in front of them. Captain Aaron Doyle stands nearby and listens as Carter anchors the priority to what the images show. Carter speaks to the team in short sentences that carry weight. Ultrasound at the bedside is the standard when noise is everywhere, and pictures cut through argument. Operating room plans will follow physiology, and not the number of stars on a shoulder. Non-clinical matters stay with the uniform chain of command, while clinical command for this bay stays with the emergency physician who holds the probe. Preparation begins for an ultrasound-guided pericardiocentesis using the best window available, subxiphoid or apical, depending on the image. A sterile field goes up, full monitoring stays on, and resuscitation continues, with a massive transfusion protocol at a 1:1:1 ratio while warmers run. Calcium replacement is scheduled at regular intervals to balance citrate, and temperature is tracked so the blood does not cool the core. The team treats this as a bridge to definitive surgery, and no one mistakes it for the final fix. The image freezes on the screen for a moment and the room goes still. The picture gives everyone the same map and the same next step. General and captain receive the same respect as before. But the plan is no longer up for debate. The truth sits on the monitor, and the path forward is clear. Dr. Lauren Carter reviews the ultrasound and confirms pericardial fluid with physiology that fits tamponade in Brigadier General Robert Whitaker. The right ventricle collapses in early diastole, and the inferior vena cava barely moves with breathing. Pressure is falling, and the pulse is fast. She states for the team that this procedure will be a bridge to the operating room to keep perfusion alive. A sterile field rises around the bed, while monitors stay attached and alarms settle into a steady rhythm. Massive Transfusion Protocol continues at a 1:1:1 ratio, as warmers hum and blankets cover exposed skin. Calcium is scheduled at intervals to counter citrate from blood products, and the pharmacist tracks doses on the board. Tranexamic acid is considered based on time from injury and bleeding pattern. Carter chooses the best window the image allows. Subxiphoid, if the view is clear, or apical, if the heart sits higher. Local anesthesia goes in. A small skin nick opens the path, and the needle advances under direct ultrasound guidance. A soft catheter follows the needle, and the syringe fills with dark blood from the pericardial space. The line connects to drainage if needed, while the team watches the numbers for response. Closed-loop communication keeps the room honest and fast. The nurse at the head of the bed confirms instruments, time of entry, and the initial volume removed. The monitor starts to tell a different story, as blood pressure climbs and the pulse rate eases by a few beats. The transport lead calls the operating room with priority for the general and repeats the handoff plan out loud. Captain Aaron Doyle stands by and receives a calm update with proper respect for rank, while clinical command remains with the emergency physician. Carter keeps the focus on physiology and reminds the room that this relief is temporary. Other patients continue along their pathways as pelvic binders hold, chest tubes drain, and transfusion coolers rotate. The bay exhales as perfusion returns, enough for safe movement, and the team prepares for the next step. Sergeant Daniel Ortiz blinks awake on the stretcher, with dried blood at the collar of his blouse and dust on his boots. His eyes sweep the room and land on Dr. Lauren Carter as she checks a monitor and adjusts a line. Recognition moves across his face like a steady tide. He nods once and mouths that she was there, and the nearby team understands without needing the volume. A brief memory surfaces and fades before anyone can name it. Night air, thick with fuel and salt. A roll-to tent, lit by headlamps, and a single tower. Rotors a distant churn, beyond canvas walls. Carter standing in that light with a checklist voice while a line of patients waited on cots and nobody pointed a camera. Back in the bay, she gives the sergeant a calm look and returns to work. She asks for vitals, and the nurse speaks them back in even tones. Captain Aaron Doyle stands at the side of Brigadier General Robert Whitaker and tracks the plan with his jaw set. Carter uses proper rank with each person and keeps clinical command focused on the sickest first. The room shifts almost imperceptibly as people register what the Marine has seen. Trust builds in small clicks as tasks land where they belong, and the teams close loops with steady answers. The general breathes with a more reliable rhythm while transport prepares the path to the operating room. Cameras murmur beyond the doors, but the bay feels quieter than it has all night. Ortiz watches the flow and lets his shoulders settle against the mattress. He sees the same discipline he remembers from the expeditionary line. Only now under fluorescent light instead of moonlight. No one asks for a story, and Carter does not offer one. The work speaks as binders hold. Chest tubes drain. And transfusion coolers trade hands in time with the pulse of the room. Brigadier General Robert Whitaker blinks into focus on the gurney as monitors find a steadier rhythm. He lifts his right hand and gives a small, precise salute from the rails. A personal gesture of respect inside the bay. Dr. Lauren Carter meets his eyes and nods once while the team keeps hands moving. The room understands the meaning without a single extra word, and the air feels cleaner for it. Captain Aaron Doyle stands at the general's side, ready with a full report that can wait. The general breathes shallow but purposeful and gives a short endorsement that points the room toward the clinical lead. Staff lean in, not to listen for rank, but to catch the direction of care that follows physiology first. Carter keeps her tone calm and confirms the plan that was already in motion. Hospital Administrator Karen Blake watches from the doorway as security holds the press line back another step. Orderlies clear a path, while the transport lead calls for an operating room slot based on hemodynamics and imaging. Massive Transfusion Protocol continues with warm blood products, while calcium is replaced on schedule. The charge nurse tracks each action on the board and reads back every change so nothing slips. The scene settles into a steady cadence that feels earned. Carter confirms triage priorities, and the teams keep working the list in the same quiet way they started. Families receive updates in plain language, while the base stays focused on tasks that matter. People in and out of uniform share the same understanding that clinical command belongs to the emergency physician for life and limb decisions, while the military chain of command manages the world beyond the doors. The gurney rolls toward surgery, and the room exhales. Not with celebration, but with clarity. Vital signs drift in the right direction. The teams reset, restock, and prepare for the next arrival. Calm, discipline, and simple language have kept this room safe through the longest hour of the night. Under fluorescent light, the night became a different battlefield, measured by monitors, warm blankets, and steady hands. The ultrasound probe stayed the compass, a small piece of truth that cut through noise and pointed toward action. This was emergency medicine as quiet leadership, not spectacle, and it kept the room honest when pressure tried to distort priorities. The lessons are simple and hard, and they carry out of this room on every stretcher and clipboard. Triage follows physiology, not insignia. And closed-loop communication beats, shouting every hour of every shift. Place pelvic binders early for unstable fractures. Start a massive transfusion protocol at 1:1:1. Keep blood warm. Replace calcium on schedule. Treat tension pneumothorax immediately with decompression and a chest tube. And use ultrasound-guided pericardiocentesis only as a bridge to surgery. Respect the military chain of command for non-clinical matters, while clinical command for life and limb remains with the emergency physician. That balance held tonight when Brigadier General Robert Whitaker supported Dr. Lauren Carter in front of Captain Aaron Doyle and the hospital administrator. Every person kept their role. Every step stayed inside protocol, and the sickest patients moved first toward definitive care. The room learned that calm language and measured pacing can be stronger than volume when seconds are thin and judgment matters. If this story stayed with you, share it. Follow the channel. And thank someone working the next night shift. Carry the principle into your own life. Because steady words and a clear plan can turn panic into progress. Remember the probe as a symbol of truth, and the single command that gave shape when chaos tried to take the room. Calm is a discipline you can practice, and tonight proved how far it goes when lives depend on it.